Good afternoon, everyone. On behalf of POCOG and the Cancer Prevention Special Interest Group, I would very much like to welcome you today to our webinar, which will be on the very important topic of health economics in the context of cancer prevention. And we are really very, very grateful and excited to have Richard and Rosalie present to us today. As you know, there has been a very long and very productive and wonderful collaboration between POCOG and the University Technology Sydney CREST and chair centers with regards to psycho-oncology research and the importance of health economics in quantifying the benefit that psycho-oncology brings to people. So this has been ongoing for a large number of years, and the team usually supports POCOG's concept development workshops. It has been absolutely instrumental in making POCOG trials the success that has been. So very great collaboration happening since many years, and lots of fantastic outcomes coming out of that collaboration. And so before we start, I would like to acknowledge traditional custodians on the many lands on which we meet today and pay our respects to elders past, present, and emerging. And obviously, we know from the cancer reports that cancer outcomes in Indigenous peoples is still not yet at the same level as the outcomes for other Australians. And so one of the amazing things that POCOG has also been doing is specific guidelines and instructions on how to close the gap with regards to cancer outcomes for Indigenous people. And so hopefully everyone can join in this quest of POCOG to help closing the gap. So I think without further ado, could I please pass over to, I think Richard or Rosalie will make a start. Richard will make a start. Yeah. Fantastic to tell us all about how can we use health economics to make the case for cancer prevention. And thank you very much again, Richard, Rosalie, and team for providing your time today for this important topic. Thank you so much.
Thanks for that very warm welcome, Monica, and it's a great pleasure to be here. And thank you for those kind words about our collaboration over these many years between POCOG and CREST. It's certainly been very fruitful. Here are my disclaimers. In addition to mine, I'd just like to point out to everybody that Professor Rosalie Viney, who will be joining us later, is the director of SHARE. She's also currently the chair of the scientific executive for the Lourenco group, who produced the EQ5D5L, amongst other instruments. And she sits on the life-saving drugs program for the Department of Health and Aged Care, and was previously on the Pharmaceutical Benefits Advisory Committee and chaired their economics subcommittee. So a wealth of expertise and experience that Rosalie brings. And between the two of us, I think we've seen most things in the world of health economics and certainly have done quite a bit, not just with POCOG, but with other groups and in the fields of cancer prevention. So with this webinar this afternoon, what we'd like to do is to give everybody an understanding for what health economics is and what its role is in cancer research, and in particular, how we can think about that in the field of cancer prevention and cancer screening. We're going to look at some of the main types of evidence that we need to undertake an economic evaluation in these settings, and then look at that specifically in the prevention setting. And we're going to do that in a couple of ways. We're going to look at a recently published review of health economics in the cancer in the prevention and screening space, and then look at 3 case studies, hopefully time permitting, to look at how people have approached this question of health economics and value assessment across 3 different types of prevention and screening, looking at HPV, low-dose CT, and the ADAPT program, which many of you will be very familiar with, I think. Okay, so what do we mean when we're talking about value and value assessment? And I always like to put this slide up because I think it's a nice way for us to conceptualize how we can think about value, because it's all about looking at how much we're getting for our investments in healthcare. And along the x-axis here, you can see life expectancy, and along the y, we can see how much we're actually spending on healthcare. And we can find Australia located somewhere over here towards the right, telling us that we're performing very, very well in terms of the health outcomes we produce, but we're not at the top in terms of what we spend. I'll just indicate who is at the top there. We can see the United States well at the top in terms of expenditure, but not so far to the right in terms of outcomes. Let's hope that this week changes that for everybody there. So when we're thinking about these trade-offs and how much we spend versus how much we get for it, we need to think about, well, where should we be investing in, and how can we determine whether or not something actually does represent good value? And does it represent value for money? So what's a good buy? And as health economists, we like to think about this, start from some key starting principles. And you can see those there on the screen. But essentially, it's about recognizing that every time we make a decision to invest in a new program or a new drug or a new machine, we're making a choice about allocating things in a different way. And those different choices and those different allocations all will have a consequence attached to them. Hopefully, the good consequences, so improving people's psychosocial status, improving people's quality of life, improving their clinical health, will outweigh any kind of bad consequences, so adverse effects or misalignment of resources that we might make. The other thing that we always try and do is recognize that every time we use a resource in a certain way, there's an opportunity cost. What does that mean? Well, it means that we are foregoing any benefits that we would have produced by allocating those resources in another way. So in a very kind of practical and concrete example for you all, the time that you're spending here listening to this webinar is time you could have spent doing something else, be it research, be it out enjoying the day if it's a nice day outside. But every time we do one particular thing, we forego how else we could have spent that time or those resources. And that's an important concept for us as health economists, because it brings to mind the notion that there is no such thing as a free resource or a free intervention, and that we always have to be thinking about how else would those resources have been used and what else would they have produced. So that idea of the comparative reckoning of what we're using, what we're producing, and how else it could have been used really underpins how we approach the assessment of value. And I'm going to take us through a couple of different ways that we look at that value assessment analysis, looking at one that I think everybody is probably familiar with, and that's economic evaluation. That really underpins much of what we do particularly in the cancer research space and in the trial research space. And the other is we'll touch on some stated preference methods and how we can use those as value assessment. So economic evaluation essentially is comparing costs and outcomes of two approaches to the same thing. And here you can see an example, a stylized example, just describing low-dose computer tomography for lung cancer screening. And we want to understand, does it represent value for money? Are the additional resources that we spend justified by the additional outcomes that we produce? And undertaking an economic evaluation is a fairly formulaic, he says, in that there are steps. There are very clear steps that we can articulate when we're approaching a study in which we want to undertake an economic evaluation, that take us through all of the important and key aspects that we need to understand. One of the most important, from my perspective as a health economist working in a cancer and a clinical space, is to understand what the intervention is and understand what it is that we're going to replace. As people who are not patient-facing and not directly involved in care delivery, this is a really critical element in setting up an economic evaluation alongside a study or even outside of a study, because we need to understand what it is that we're doing, what we require to deliver those services, and what we expect to change as a result of the intervention. That really lays out the rest of the steps in the evaluation in terms of ensuring that we're collecting the right data to answer the question in which we're interested. And I'm going to take us through some of these other steps here in more detail as we go along. The type of evaluation that we do is really determined by some assumptions that we make around whether or not the two interventions that we're interested in produce the same outcome and to the same extent. You'll see that I've got one bolded here, and that's the cost utility analysis. And I've bolded it for a number of reasons. There's a very pragmatic reason I've bolded it, and that is because decision makers around the world, people who are using the results of these sorts of studies to make decisions, are very often requesting that we present evidence from cost utility analyses. Well, why do they want that? And why are these perhaps the type of analysis that we're most interested in? The key comes in the metric here that we're measuring, which is the quality adjusted life year. And the quality adjusted life year, as the name suggests, looks at the outcomes that we're producing in healthcare and in clinical studies, and says, we're not just interested in how long people live, but we're also, and critically, very interested in that nexus of how well they live. So we combine those two things into a measure called the QALY, which by not only gives us the outcome that we're most interested in and that patients are most interested in, that combination of length of life and quality of life, but over time gives us a consistent metric to allow us to make decisions. We're going to return in a minute to how we measure QALYs and in particular whether there are implications there for prevention and screening studies. Obviously, as a health economist, I'd be very remiss if I didn't talk about costs and how we can assess costs broadly, and then in particular how we might think about them in the setting of prevention and screening applications. I've said here that there's really no magic to how we estimate costs, and honestly, there isn't. It is about being very clear in understanding what it is that we're doing. So identifying the resources that we're using when we're delivering a service. Who's delivering the service? How long does it take them? Are there any unintended consequences that we need to be mindful of? And do those consequences actually carry additional treatments? And then measuring all of that resource use. So the number of times that people come in for a visit, for example, how long they're there, who's involved, all of that needs to be captured so that then we can assign what we call prices or unit costs to each of those resources and then be able to aggregate them up into the assessment of a total cost. There are some things here that we need to be thinking about, though, when we're assessing costs. One of them is, which hat are we wearing in terms of perspective? You might have noticed that as a step in the study design procedure. Perspective is really important because it says, am I doing this from, for example, the societal perspective or the government perspective? And that has an impact on what we might measure when we're assessing costs. So the broadest perspective that we can take is the societal perspective, where we collect information on everything that is used, regardless of who actually bears that cost. So if, for example, we're looking at an intervention that has very high travel requirements or has very high impacts on time off usual activities or people being away from their home, then we might want to take a societal perspective so that we can ensure that those impacts are captured and we can report that fully within our analysis of value. So that question of perspective is really an important one that helps to then impact on how we assess the cost. The other one that is important in terms of cost is the time horizon. And what I mean by that is, how long are we going to not only observe healthcare resource use, but how long might we then actually try and estimate costs associated with the condition? So within a trial, we might observe healthcare resource use for 2 or 5 years, depending on how long the trial is. But we might know from natural history that that condition has impacts that go on for another 20 or 30 years. So we might need to have a time horizon that extends beyond the study to allow us to capture those effects. This is quite critical when we're thinking about a prevention setting and looking at determining value in the context of prevention interventions, because quite often we have an intervention early on in a disease course, but we don't see an effect until quite some time after that. And it really raises the question of whether or not we can attribute those later effects that we are anticipating or hoping to see to that very early on intervention. So attribution is key within the idea of a time horizon. So how long reasonably might we extend a time horizon and still have confidence that the effects we're we're assuming, including costs, are actually attributable to that earlier intervention. Thinking about the practicalities of collecting some of this information, obviously everybody knows that we can directly measure things within the context of a clinical study or a clinical trial using CRFs and other primary data collection means. And you can see here that I've identified that sometimes we need to ask patients about things like time off usual activities, or how long it's taken them to drive to an appointment, how long they've spent away from home. The other really important aspect to data delivery for Australia is thinking about, and indeed for other countries that have administrative data sets, is thinking about, well, are there existing data collection methods that allow me to tap into this idea of measurement of resource use without me putting it in the trial? And we can do that in Australia by consenting patients to access to their Services Australia data. That gives us MBS and PBS use. There are separate requirements in terms of hospital data sets. But all of that allows us to capture in a much more direct way and straightforward way what's actually happening to the patient outside of the trial or alongside of the trial. It also potentially allows us to capture those downstream effects that we might not see immediately within the confines of a trial. And in particular, for a prevention intervention, they might be a good way for us to capture those ongoing resource uses and ongoing costs. What we need to think about, though, in prevention space and in the capturing data for prevention and screening studies is how we are actually going to make this prevention program or prevention intervention successful. And quite often, many of these programs require resource activities and spending that sits outside of the direct healthcare program, or what we normally think about in terms of healthcare, in terms of education, or in terms of mobilizing resources that otherwise it might be used for delivering healthcare, particularly if we're thinking about things like vaccination or other such programs. So we, in thinking about how to assess those costs, we need to actually make sure that in the identification step, they've been well thought about so that we can put in place the right measures to collect that information. So moving on to outcomes, which I think are perhaps the more interesting side of this equation than the costs, particularly when we're talking about something like prevention and screening. As I said previously, we usually focus on assessing quality adjusted life years, which inform a cost utility analysis. So we have this combined impact of length of life and quality of life. And within a clinical trial, this is no surprise to anybody on this webinar, we measure patient-rated quality of life using existing questionnaires, to which we then apply existing algorithms that tell us how those different experiences of health are valued by members of society. Now, that's a quite complex process that the developers of those questionnaires have gone through to be able to translate those patient ratings or health states into societal values. It's something that we as users of those algorithms don't necessarily need to worry about replicating in the context of our clinical studies or studies looking at value, but it's good to have an understanding that those exercises have already been done. So what we're doing in a trial or in a clinical study is to have patients rate their quality of life using those questionnaires and then apply these existing algorithms to those what we call preference-based measures that give us utility values that we can then apply to the length of life to estimate QALYs. And here I've just highlighted an example of one existing measure that we can use in the cancer space that is specific to cancer that allows us to collect information on the underlying health-related quality of life measures using the FACT-G, and to then convert that to these preference-based measures for use in a cost utility analysis using something called the FACT-8D, using the 8 domains highlighted there. And you can see that there's a really nice benefit there to participants in a trial because they're not having to do 2 questionnaires, but we're still getting all of the information that we need to be able to conduct a value assessment. Again, for you and people who are involved in POCOG, you know that choosing the right questionnaire is critical. And alongside CREST, there is the CQuest service that provides advice and support on the choice of questionnaires for cancer clinical trials in terms of quality of life. And they also can assist with the quality of life questionnaires for health economics. But just importantly, and not to belabor this, is just to say that different questionnaires will load on different domains. So we need to think about which domain we are most interested in. And you can see that nice graphic at the bottom there that tells you how those domains load differently. But also think about whether there are other regulatory or budgetary concerns in choosing a particular questionnaire. So coming back to end use of some of this information, someone like NICE in the UK asks that studies use the Euroqual EQ5D3L when doing their evaluations, whereas someone in Australia, we don't have similar requirements. I've already stated that we've got the FACT-G that's now cancer specific. We also have the EURTC QLQC30 that allows us to produce values for economic evaluations by applying the QLUC10D. If we're then focusing on what all of this means in the prevention and screening space, we can see automatically that preventing a particular condition and a particular clinical event has value in terms of quality of life. But what about some of those psychosocial aspects? What about reducing anxiety and fear of contagion, for example, that might arise through a prevention or by people engaging in a screening program? And this is important because we need to ask the question of whether something like the Euroqual measures that have anxiety as a particular domain would be able to capture that particular aspect of anxiety, or whether we're talking about some other state trait anxiety that might be impacted on by these particular interventions for prevention or screening, or whether we need to be thinking about other ways of valuing these impacts associated with those prevention and screening interventions that might not sit neatly within one of these existing quality of life questionnaires, but are nonetheless relevant and important to how we might assess the value of the prevention. And when we get to stated preference methods, I'll show you how we might try to do that. Once we've combined our costs and our outcomes, obviously we come up with a number. We come up with a cost effectiveness ratio that is the ratio of the difference in our costs over the difference in our effectiveness. And the users of this information have to assess whether or not it represents value for money. The key takeaway from this slide is that we very rarely see interventions that have a ratio down in this quadrant with the green traffic light. They would be great if we did. We sometimes see them in the quadrant with the red traffic light. That's an easy one. They're too expensive and produce less. We throw them out. They're not things we would consider value for money. Where we typically operate is in this quadrant up here, C, where we have a higher cost but more outcomes, and we have to assess, well, does that represent value for money, and how much are we as a society willing to pay for those additional outcomes? And there's a few questions here that we can think about. The first is that we don't have, in this country at least, a set threshold that our health technology assessment agencies and our government have explicitly stated they are willing to pay for outcomes in funding new technologies and new interventions. So that allows us a degree of pragmatism in assessing value for money on a case-by-case basis. The other thing that we need to think about is whether we should have different thresholds depending on whether we're talking about a treatment or a prevention space. And indeed, there's a school of thought that in the prevention space, where we might have less certainty because of the longer time horizons associated with outcomes arising, then maybe what we should be seeing is a lower threshold. So we want things to be cheaper per outcome produced than we might be willing to pay in a treatment context, particularly in a treatment context where we have kind of end of life or more advanced disease being treated. So I want to turn now to what we see in the literature, focusing on methodological issues around disease prevention and health promotion. And I don't present this as being the only piece of work out there that's looked at this. There have been others. This particular review, as you can see, had a large number of underlying studies, almost 500. I can't imagine how these authors went through nearly 500 studies, but kudos to them. And you can see that most of the papers that they went through were on a group of disease prevention and health promotion as a collective, but did also focus, have a large number on behavioural and lifestyle interventions. What they were looking at were three key areas: whether or not there was consistency in, or how they were thinking about the attribution of the prevention effect to the final outcomes, how those final outcomes were actually conceptualized, what they were looking at in terms of the impact of outcome in determining value, and then whether or not they were capturing any effects beyond health and beyond the healthcare sector when they were thinking about perceptions of value and sources for value within the context of these particular interventions and programs. Sorry, I'm just going to take a quick drink. Always good for television when someone takes a drink. So you can see here that they've grouped the findings for those three outcomes under attribution, outcomes, and the non-health effects. What we see is that coming to that question about the attribution and the time horizon, the majority of the papers and the studies that they looked at had quite a limited time horizon, in that they were focused on trial-based analysis. That's what TBA stands for. They were focused really on that short-term horizon, and only 23 out of the papers out of the studies that they published on actually had a lifelong horizon. So the attribution for most studies was very, very short term, which suggests that they don't have a good handle on what's happening in the longer term and being able to make claims about whether or not the prevention outcomes we're going to see in the long term were justified by the early interventions. We also see a very, very high proportion of studies where this was reported having a societal perspective as the basis for their analysis, which gives us an indication that we are thinking about effects and thinking about costs beyond those that accrue to the health system or the government, and therefore thinking about some of those other impacts on participants in these programs. The basis for the outcomes was in most cases intermediate outcomes, like cases detected. So they weren't necessarily all focusing on things that we have been discussing here so far this afternoon, which are the more preference-based outcomes, which you can see were captured in fewer studies within this review. What was interesting was the inclusion of effects beyond health. And you can see productivity, which is something we would reflect in a societal perspective, was the main beyond health effect that was included. But we also saw other individual and family effects reported across these studies, and potentially even going to inclusion of education and criminal justice impacts for some of the prevention studies. And this is just to highlight that we don't have to approach all of these studies with the same lens or the same thinking about things in exactly the same way, that we can be more expansive. And indeed, there are examples out there in how we can change our mindset and change how we approach things. All of those studies use a kind of economic evaluation framework when they were looking at this notion of value and value determination. And that really rests on the idea that we have or can observe within a trial what happens when we allocate people to one program versus another. But another way that we can look at determining value is by going back to that notion of choice and harnessing the idea that the choices that people make really do reveal where they're placing value and how they trade off between different characteristics of a particular program. So in the context of a prevention program, we might be looking at how people might trade off between risk and reassurance and potentially reductions in anxiety versus participating in a very short-term program of screening or a short-term program of assessment with a practitioner. So the way that we do this and the way that we harness the value of choice in this context is using discrete choice experiments, which are a long-standing experimental methodology, survey-based methodology arising from environmental economics and transport economics that's been used in health economics now for quite a number of decades. And they are very, very powerful in allowing us to conceptualize choices that might not otherwise be observed in practice, or to investigate aspects of choice that we can't easily conceptualize within our existing questionnaires and health-related quality of life questionnaires. So we can think about asking people to make choices between different health states, for example, that might impact on different aspects of quality of life that we're particularly interested in valuing. And we can look at how they trade off between those different aspects. And that gives us an idea about not only the sources of value, but potentially how individuals might use different programs differently, or how we might actually be willing to pay for those different aspects of programs. And I've got here an example, it's a few years old now, of some work that we did back looking at what influenced decisions to undergo prophylactic mastectomy. And what we were looking at here was whether or not women would undergo CPM or whether they preferred monitoring. And what we found was that there was a very, very strong underlying preference for one over the other, irrespective of how we describe the programs. So there was a group of women who were very much pro-monitoring and another group of women who were very much pro-contralateral prophylactic mastectomy, irrespective of how we describe those two programs. And then there was a group of women who were actually influenced by how it changed their risks of further cancer and how involved they were in the decision-making process and whether or not they were actually part of that ongoing clinical decision-making. What we were also interested in here, oh, sorry, I thought there was a pop-up there. But what we were also interested in here was the influence of cancer concern. Now, within something like a DCE, we can't conceptualize of a choice where someone is told that they are more or less cancer concerned. But what we did explore was whether or not when people were completing the survey, how much they were concerned about cancer reoccurring based on the vignettes that they were reading. And we used that as a stratification within the analysis. And you can see from the text boxes on the right here that did help us in differentiating those who were more likely to prefer either contralateral prophylactic mastectomy or those who were willing to make a trade, as opposed to those who preferred monitoring. So women who always preferred monitoring were the least concerned about cancer recurrence. And therefore that tells us that we can differentiate values for not only these attributes, but also in terms of willingness to pay between those who were cancer concerned and who were not. So this is quite a powerful tool. Discrete choice experiments are quite a powerful tool that allow us to unpack some of those underlying values and how people might participate in a program. It does raise the question whether all studies need health economics. I'm not going to belabor this. You can see what's here on the screen. And I will say that CREST has also produced a checklist that allows you to go through these questions about whether a particular study that you're planning, be it in screening or prevention or something else, might benefit from from a health economic analysis. And there are some particular questions around the study aim, the quality of life effects, how we're describing resource use and indirect costs, which comes to that question about perspective, and whether or not there is a particular question around preferences that might lend itself to doing a discrete choice experiment. And that all leads you to a little checkbox that will tell you whether or not talking to CREST by the POCOL exec is something that you should do. I'm going to switch gears now and come to our case study, and I'll talk to two of them and then we'll go over to Rosalie to talk us through the last one about ADAPT. The first one here is a case study that some of you might know, and one that Australians should be very proud of, which is the introduction of the HPV vaccine. And what I want to highlight here is how this particular vaccine, which has at its core the prevention of HPV-related cancer and other lesions, was viewed by the Pharmaceutical Benefits Advisory Committee. And when it was first taken to that committee, they were seeking funding for females 12 and over, and we know that group, because that was where they felt they were going to get the best reductions in downstream lesions associated with HPV. And we also knew from that time that Gardasil, which was the first vaccine, and I've used its trade name here, covered the 4 most common types of HPV. Sorry, lost my train of thought there. What they presented was a mix of vaccine efficacy in terms of preventing more intermediate grade conditions like CIN, that should say genital lesions, not genial lesions, although I hope they are all genial, and genital warts, and some immunogenicity data. And for those who aren't aware, immunogenicity data is telling us about the strength of a vaccine in being able to cover the particular serotypes to which it is targeted. The trials were of limited duration, so 5 years, and we know that particularly for cervical cancer, the development of more serious disease is going to happen later in life, so is going to be associated with a much longer term effect. Now, the PBAC, when they looked at this, they said, yes, we agree that this is more effective than having no vaccine, but it does have some toxicity associated with the vaccine. What they weren't certain of was that downstream impact on being able to reduce the incidence of cancer and the extent of cancer that would be impacted. When we look at the particular issues associated with the cost effectiveness analysis that the company submitted, and this is public knowledge, what we know is that there were concerns about the attribution of the prevention measure, so the vaccine, in terms of those downstream impacts. So what timeframe are we talking about for cancer to occur? Is this going to have a lifelong impact on individuals who are vaccinated? You know, how long does the effect actually last? And then whether or not the results from the trial reflected what would actually happen in Australian practice, given that we had other programs around cervical cancer prevention at the same time, and whether or not this would instigate a change in behaviour that might lead to different outcomes in terms of that clinical impact. The outcome that they were looking at was, would there be herd immunity effects, which we would always hope for in a prevention setting, but also whether or not we would see a shift in the serotypes impact of causing HPV-related disease, moving away from the four covered by Gardasil, so that we're actually not seeing the impacts that we were hoping to see. And the committee was also questioning how much of a reduction in anxiety we might see associated with the introduction of this vaccine. Could there be greater benefits than were included in the modelled analysis? I've already talked about the impact on screening behaviours. Finally, from the cost perspective, one of the important elements of this was ensuring that they did cover all the education and implementation costs, because, as I mentioned previously, those are a critical factor of any prevention program. So when this first went to PBAC, they rejected it on the basis that the cost effectiveness ratio was too high, and for many of those reasons, they're largely around the attribution of the longer term outcomes. The company then came back at a lower price and made some other changes to the modelling to ensure that they met those questions that PBAC had phrased. But the PBAC kind of at that point had said, come back with sharpen your pen and come back and tell us that you've got a lower ratio, particularly when we're comparing this to other population prevention interventions. So they were thinking about, should this have the same value as a lipid lowering or an antihypertensive drug? So it's giving us that idea, or that notion that in a prevention setting, we have a different value that we're attaching to our actions than we are in a treatment setting. So something to be mindful of when thinking about setting up these sorts of studies. The other one I want to focus on before I hand over to Rosalie is one that is quite imminent, and that is the introduction of low-dose scanning for lung cancer. And we know that this program is to be launched mid-next year. An rapid evidence check review that we conducted for CANSW back in 2019 showed us that there was quite a plethora of studies looking at value in this setting. And you can see here that the range of cost effectiveness, particularly when we look at the cost per quality, was quite high, going from well below 50,000 to here. This is the Australian study here in the middle by Wade et al., which is approaching the $250,000 per quality. A more recent Australian analysis based on the Nelson and NLST has since revised that cost effectiveness for Australia and brought it down to numbers that look much more appealing and much more like it's cost effective, and they're therefore supportive of that broader population implementation. What we know from those studies, including the more recent one, was that value in this setting is really impacted by how we change people who are being screened. So if we apply different risk criteria, that risk selection, that changes who is benefiting, not only the cost, but it changes who is benefiting. It is the value is certainly impacted by those downstream assumptions about the events that we're avoiding. So if lung cancer treatment goes up, then that makes it more valuable to be screening people now and avoiding those later term disease and its management. Duration of effect is critical, as is the impact of false positives and thinking about false positives from a psychosocial perspective. How anxious are we making people by giving them false positives? Because it not only means that they have to engage in care, but we're causing potential harm, telling them they have something that they may have something that they don't, and how might we measure that? And then lastly, we know that the preceding assessments of cost effectiveness all showed that the success of these programs is really impacted by uptake of screening rates. If you don't get people participating, then they're not going to be as successful because you're investing in their implementation, and if people don't use them, they're not going to work. So to that point, Nicole Rank and colleagues, and I'm part of this group, we've been very interested in understanding what's the best way to implement a screening program in the context of lung cancer screening in Australia. And so we've just completed a discrete choice experiment that's currently in the manuscript write-up stage, and that's looking at these key aspects of how the program is constructed in terms of participant invitation, assessment for eligibility, how they book appointments and the subsequent care they receive, and whether or not they've got healthcare worker support for participating in the program. And as I say, that's currently it's been drafted, but has come up with some very interesting results, particularly around that additional healthcare worker support and the importance of having that support. So I am going to now stop, and I'm going to turn over to Rosalie, who's going to tell me when she wants me to flick slides. Thank you, Rosalie.
Thanks, Richard. And I'm just going to talk about a third case study, which I think will be dear to the hearts of many of the people on this webinar. And in fact, many of them will know more about it than me, or about certain aspects of it. So, as I said, many of you will be aware of the ADAPT program, which was essentially a screening service in psycho-oncology care. So the idea is that it's very easy for people's psychological well-being to not be captured when everything else that's going on in cancer is happening. And so the intention of this was to develop a pathway that would mean that when people came to the service, they were screened and allocated in terms of, or allocated is the wrong word, but screened in terms of sort of determining whether they were suffering any psychological distress, and then there should be appropriate referral. So this is, there are many people here, Joe included, who are involved in ADAPT. I think I saw Mona's name there before too. And I also just want to acknowledge that this is Jackie Yim's PhD work that I'm presenting here. In fact, these are his slides that I'm presenting to talk about this. So we might just go to the next slide. So I'm not going to talk a lot about, oh, sorry, can you just flick it on? So Richard, it's obviously got some fly-ins. I'm not good with fly-ins. I thought I'd remove them. I'm mostly going to try and talk about the health economic outcomes here. So the idea of ADAPT, as I said, is really that if you pick up people with psychological distress and refer them appropriately, there are two possible things. One is hopefully they get better management of that psychological distress and so don't have long-term downstream sequelae. And that might or might not save costs. And that's one of the things, I think Richard mentioned this before, it's important to remember particularly with prevention and screening. So with the lung cancer screening example, it's kind of obvious. Can we just go back one? Yeah. With the lung cancer screening example, it's kind of obvious that what you're doing is you're hopefully treating people much earlier. And so you are likely to be saving downstream costs because later treatment is likely to be more intense. But what might be happening here is that these are people who wouldn't be getting treatment at all. But hopefully what you're doing is you're referring them to appropriate treatment that is for the level of distress that they have, and therefore they will be getting care. So they might actually end up being both higher costs and better outcomes. And I think it's really important that we remember that when we're talking about prevention particularly. Okay, so just to tell you a little bit, and I'm not going to talk a lot about the ADAPT trial overall, but it was a trial, and in particular, across all of the sites that were involved, the screening service was implemented, but it was at 2 levels. So one was a more enhanced, supported implementation, and one was more a basic one. So the outcome that was in the trial was adherence to the treatment pathway, to the screening and treatment pathway. Obviously, you're also interested in the psycho-oncology and implementation science outcomes, but what I'm talking about here is the health economic outcomes to the extent that we were able to measure them. So what we're interested in is how much does it cost to actually implement the ADAPT protocol and set it up in services so that when people come into the service, they get screened and get referred appropriately, and that happens as part of their routine care. How much does it cost to deliver it? Because obviously you've got to set that all up. Then how much does it cost to actually deliver it? And then to compare the 2 implementation strategies, the core versus enhanced. And obviously, because every service had the program in some way, that was the point of comparison. And as Richard said, we need a comparator. Now you can jump to the next one, Richard. Thank you. And again, could you just jump? Yeah. So that I know everything. And no, go back one. Sorry. Okay, so as we said, it was implemented across 12 cancer services for 1 year. They were randomized at the site level. And just to remind everybody, the difference between the sites was in terms of whether they had the core level of implementation, so minimum support for implementation, or enhanced, which was much more support in terms of training the staff, having champions, having more support along the way for those services as they implemented the program. And as I said, there are people who are much more into the detail of that than me, who might be able to answer questions if you're interested. Now, can we go to the next slide? Thanks, Richard. Okay. So what we were interested in here, and on Richard's slides before, we didn't have cost consequence analysis. This is another form of economic evaluation, which is often applicable in complex services where you've got multiple outcomes that can be occurring, and they don't necessarily naturally all feed into something like a cost per quality. But it is important to be able to say, well, here's the difference in costs, and here are the different outcomes that we get. And in particular, in this case, because this trial happened at the same time as a global pandemic happened, and so there was a lot of complexity around the actual rollout and being able to get some of the final measures, we didn't have all of the detail of the outcomes of the trial, but we needed to do this economic evaluation. So, and I think it's actually a really interesting economic evaluation, because what it does is then concentrate on what are the costs of delivering this service, setting it up, implementing it on a per patient basis, on a per screening basis. So basically what we're talking about is a screening event is when somebody's screened, which could be happening at multiple times, and a per patient is how many patients can be screened. Okay, so this is another way of being able to think about doing economic evaluation, to be able to make the decision maker understand the whole range of outcomes, but not necessarily to be able to put it into a straightforward incremental cost effectiveness ratio. We do see it quite often in these interventions that have got multiple aspects. Can we go to the next slide? Okay, so just to give you some of the results, here is the comparison of cross-core versus enhanced, and then the average across the whole trial of implementation costs, the in-clinic practice cost per patient. Thank you for the highlighting, the total annual cost per patient, and the total annual cost of the program. So you will see that the enhanced was more expensive overall. It did cost more to deliver the enhanced, and that's not surprising. What we would hope is that there is more adherence to the treatment pathway, more effort in terms of making sure that patients actually do get screened, etc. And so ultimately you'll get more outcomes, and you can see that to some extent. If we go to the next slide, this is the cost per screening event. So the same sort of comparison across the core and enhanced, and then the average. And so we can see what the cost per screening event is. Yeah. And then the next slide is the one that I want to mostly talk about, which is a really nice graph that Jackie prepared, which looks at the average cost per patient at each clinical site. And we can compare it across the core and the enhanced, and we can look at small sites and large sites. And I think what really shows here is that with programs like this, the cost effectiveness to some extent is going to be a matter of scale. So if you are implementing a program like this in a busy cancer center that has lots of throughput, then even though it might actually take more effort to get everybody on board, you will likely end up with a lower cost per patient because you've got more throughput and more people being screened as well. And so I think the outcome out of this is really to say, and you can see that it's not really to do with whether it's core versus enhanced. It's actually to do with how many patients, as much as anything, there were in the sites that drove that cost per patient. And I think that's an important thing to be aware of with a lot of services when we're implementing them, thinking about it, that there are ways that they can be implemented. And so a service like this, which is a fantastic service, to have it really supported when you've only got 20 patients a year, sorry, that may not actually be a relevant number, well, actually it is going to make a big difference compared with when you've got a lot. And I think that's actually the last slide on this, Richard.
You are quite correct, Rosalie. It is the last slide. Thank you. The next set of slides were about, the next slide was about some key takeaways, but I'm very conscious of the time and wonder whether we return to you, Monica, because I believe we had some more discussion, or if you want to open it up for Q&A.
I think maybe the key takeaways would be great to just go over, because there was a lot of content, and
yes,
we
did cover
it all up. Thank you.
Thanks, Monica. We did cover quite a lot. So just to summarize what we've just heard, I think, is the methods that we're talking about in understanding value really draw quite strongly, and is the application of health economics. We don't necessarily need to include them in the same way for every study, but we definitely do want to be thinking about them when we're setting up studies, whether they're studies in prevention and screening or any other study. And it's important to be thinking about those methods with a view to, well, what is it that we want to change? Why is it that we're doing this study? And how do we want to use this information later? Because that will then determine what we collect, how we collect it, and ensuring that we're answering the right question. So thinking about that role for health economics really early on is important, particularly around that identification of what's relevant to the question we're asking and how those data are going to be used. The application of health economics to a prevention setting versus a treatment setting is one that does require us to think a little bit about what we're going to measure and how we're going to actually demonstrate value, particularly around that notion of attribution in effect, because we're quite often observing an effect that is very, very proximal in terms of a study, in terms of a prevention of an event, but we might be very interested in outcomes that are quite distal, and therefore can we actually, within the confines of an economic evaluation, make that claim or make a claim about being able to assess the relative impact on a distal outcome from a proximal event, and how that impacts on value. the outcomes that we choose are really critical, not just in terms of the evaluation type that we do, but also in capturing what we're most interested in. And Rosalie just gave us a great case study about how we can potentially be more expansive in terms of the outcomes that we present through something like a cost consequence. But alternatively, we might choose to do something that an approach to valuation that allows us to explore outcomes that are not directly captured by our standard metrics. So using something like a discrete choice experiment, for example, might help us to think about those outcomes a little bit broader than what's in our standard questionnaires and our standard forms, for example. And lastly, again, just to think that often in the prevention and the screening space, we are looking at things that might have an impact beyond health. And is that something that we're interested in capturing and reflecting within our value assessment? That, of course, will broaden the type of analysis that we need to do, but it may have potential implications for whether or not we can demonstrate to a decision maker that it's worthwhile paying for a particular new program or intervention, whatever the case may be. The last slide here is just about getting advice from CREST in our group. So I'm happy to stop sharing there and hand it over to you, Monica.
Fantastic, absolutely fantastic. Can we please all put our hands together, thanking Richard and Rosalie for such a great summary and insightful slides. Yeah, I learned a lot, and thank you very much for that. So would everyone just like to come off or turn their videos on so that we can have a discussion? And while everyone is coming off, could I just ask Richard and Rosalie, given the examples that you have provided, for example, HPV vaccination and ADAPT trial, can we use those examples to then argue to the funders a bit more effectively now to say, okay, we have all these examples. Does that mean that it makes it easier for the health economics value to be shown, similar to how, I guess, medications can always argue there's this other medication that has already shown effectiveness? Is that sort of helping to build up the evidence base to make it a bit easier to argue for preventive programs?
So I'm going to have a go, and then I'll let Rosalie have a go. I'm a great believer in we're not lawyers, but case law is fantastic in whichever area you want to think about it. So having examples like this where health economics has been applied in a prevention setting certainly makes it easier for those who come next, because it allows us to look at what the issues were and how they were dealt with, so that we can then, in going to decision makers, actually either show precedent or say, that's not an area I want to go down, or ensure that we answer the questions that were being asked. So for me, that question of the longer term attribution is a really important one. And if that's not addressed correctly or appropriately, then people will rightly ask questions. Do we think we're going to have that downstream effect and that long-term impact, and how confident can we be in the results? So looking at this kind of existing precedent, I think, is critical when we're thinking about applications in prevention. Rosalie, what do you think?
I just wanted to reiterate the point that we were saying before, that I think these do create the evidence base, but we have to remember that evidence base is not necessarily about saving money. It's often about better outcomes. And so, it's that saying an ounce of prevention is worth a pound of cure is a real, it sounds easy, but it's a bugbear, because often it's true, but it's not because it saves you the pound of cure. Because it might cost you quite a lot more than an ounce of prevention to save the pound of cure, but you are getting better outcomes. I don't know if that was very clear, but
yes, it's not so much about you're saying, okay, don't focus necessarily just on the costs.
Yeah,
focus on all the other things you're getting, but then they are often hard to prove, aren't they? Especially in the cancer setting, where people might get all kinds of other illnesses that are competing as they age. So yeah, a really interesting conundrum there. So yeah, opening it up to other people's questions maybe now. So
while you're waiting for that,
yeah,
that question. Now, what was I going to say about that? It reminded me. Yeah, I think that there is a real challenge in cancer, particularly when we come to things like psycho-oncology treatment, because you've just got the kind of, you've got the whole aspect of the cancer treatment that kind of in many ways can so easily outweigh these other things. And so when we try and measure it in outcomes, it may not be obvious, and yet it's really important. So in some ways we have to sort of think really about the heterogeneity of that population as being a relevant aspect, because if somebody's having a really challenging cancer treatments and undergoing surgery and chemotherapy and all of those things, and what you're intervening on is their mental health and well-being, it may not show up compared with the pain and things like that.
I guess, Rosalie, it's Jo. Just thinking about that, and the other analysis that Jackie did as part of the ADAPT trial, looking at MBS and PBS data, and the change in health services use in connection with ADAPT is an interesting example of what you're talking about, really.
Yeah. And in two ways. One, you might see changes in health services use that you say, okay, here's this change in health services use. This is increased, but actually this is services that you want this person to be having compared with, and particularly when we talk about anxiety, what you might get is that people are much less likely to, if they're getting proper psychological treatment, that they may be much less likely to use regular services, so much less likely to be going to their GP at the drop of a hat, because they're more able to manage that anxiety or understand their symptoms. So I can't overemphasize the importance of these kind of programs, but yeah, we need to really think quite broadly. And that's why, as health economists, we'd always say, yeah, you might be interested in this particular service, but actually, if you're going to measure health service use, look at the whole of health service use, because it may tell a story that's quite different from if we only look at particular services.
And that's the importance of thinking about using administrative data.
Yeah.
Great.
Yeah. So I might just, sorry, was somebody about to...
No, you go, Rosalie. You go.
I was just going to talk again, and Lutfen would know about this example. So in other work that we've done recently, which was kind of about prevention, but it was about intervening on people's homes in Victoria to make them more energy efficient and warmer. And we did look at health services use there as well. And again, I just want to emphasize the importance of the fact that, so originally when that trial was designed, it was only going to look at COPD, pneumonia, and those sorts of outcomes, asthma. And we argued that it was really important to look at all the services, because in fact, it might be quite different services, again, that change as a result. Plus, of course, if you don't measure them all, and you don't see a change in what people are doing in terms of GP services, because they're actually not in hospital or in hospital, and you haven't measured that, then you need to actually have a look at the whole picture for a person.
And what did you find, Rosalie? Was it an unexpected health service that actually changed through that intervention? Or?
This is another COVID-affected study. And so we didn't get quite as big an effect in terms of health services use, although there were changes in health services use and some savings in health services use, but it wasn't significant, so I don't want to put too much emphasis on it. What we did see is that people's houses were warmer, they did feel better off, and they did have better health outcomes as measured on at least a couple of the measures. Yeah.
Fantastic. Yeah, very good. Other questions for Rosalie and Richard?
Monday, everybody's shy.
Or
they're just stunned and quiet ahead of the election in 2 days.
Jo's resisting the urge to say, how's that paper coming along, Rosalie?
No, I wasn't. I was actually going to ask, sort of a very pragmatic question. When do you think it's worthwhile starting to engage with health economists when you're thinking about a research question and thinking about sort of developing up a trial?
So I would always say early, straight, you know, as soon as you've got the research idea, because then you can be thinking about, is it applicable? Am I collecting the right data? And, you know, health economists are a weird lot, and we sometimes think about research in a slightly different way because we're always thinking about that comparative nature. So even getting us to think about the research question, you might find that the research question itself changes slightly. It might not be applicable for an economic evaluation or a health economic analysis, but we might even say, have you thought about approaching the research question this way? So I think even from that perspective, it's useful. There is a school of thought that says use health economics to help define where you should be doing the research. You know, is it worthwhile investing in doing the research in a particular area? That's challenging because that means that you have to go and find people who can do these analyses before you've even conceptualized and conceived of the research question first off. But it is always earlier is better than later. It's not that you can't do these analyses after a study is done. You can, but it's always fraught, you know, as to whether you've collected the right information.
Wendy, you have your hand up. Oh, sorry, Joe, you wanted to maybe follow up with another? No?
No,
Okay.
no, go for it.
Over to you, Wendy.
Thanks. Yeah, thanks for the great presentation. Thanks very much for the great presentation. I have a question, or probably more like a comment. I'm working with culturally, linguistically diverse background group. I know, I mean, cancer screening or prevention is much more hard work in that group. Just wondering, in terms of assess the outcome, should we actually have, I mean, definitely we will include those outcomes, but any additional outcomes be able to reflect the value? For example, I just feel like some of the prevention program probably not just for, how to say, it's more likely influence the whole family than individual. And I feel like the outcome measures normally won't be able to reflect that. So just would like to know what's your comments on that. Thank you. Yeah.
I would agree with that entirely, Wendy, and it really exemplifies for me why it's important to think about these questions early, because in a cold setting, we might well conceive that the outcome measures we might usually apply don't capture everything that matters, or may not capture it in the way that we think. So, you know, those family impacts might be very, very relevant. And therefore, if there's not an existing measure to address them, how else might we capture it? How else might we reflect it? And so thinking about it in that early phase is going to be really, really critical. I saw a study recently which was looking at colorectal cancer screening for a core population and a particular intervention that had been developed. And they looked at all aspects from the intervention all the way through in terms of what did we need to do in this population to make this work, and then what was the outcome. So I think thinking about it very, very early on is critical. And to your point, then thinking about, well, how else can I capture this outcome that I'm interested in, this familial impact, will be important. And, you know, to the ADAPT example, it might be that a cost consequence is a way to do that, to then lay out those values beyond the immediate health impact.
Maybe following on that then, Richard. So in your presentation, you really talked about most studies only measuring the short-term consequences, not so much the long-term, and probably because it's much harder to estimate that. But Wendy's question sort of speaks to that, doesn't it? That if you prevent a cancer and then all the downstream impacts on not only the person themselves, but the family and so on, So how do you deal as a health economist with that conundrum that you have so many unknowns, and are the modeling systems that you're using?
So the models can be very complex. We don't tend to use in cancer at the moment, we don't tend to use something that kind of would include something like those secondary contact matrices type effects that we might see in infectious disease, for example. But that doesn't mean you can't incorporate carer impacts or family impacts beyond the individual. But the models that we have these days can be very, very complex, down to patient level simulations, discrete events simulations. What I would say, and I guess I say this as a caution, something of a caution, think about the complexity of the model, and is the data requirement, because these complex models are very, very data hungry, is it really going to be worth it in terms of the result that it produces, over being able to making assumptions around a more standard model, and then recognizing that there may be effects beyond that. I guess the reason I say that is those data hungry models all need inputs. So the more that you try to capture in a model and the more granular you try to make it, the more data you need.
Right.
Yeah, and Richard, I've just put a comment in the chat there that I think these things are really important, but in some cases they can be additional outcomes that can be presented in discussion and summary of findings, rather than trying to, do a double pike half flip to get it into a model.
I think Sonia had a question too.
Yeah.
Or comment.
No, question. I'd just like to ask Richard and Rosalie if you've done any evaluation of consumer involvement in cancer care.
Now, what do you mean by?
Yeah, what do you mean by evaluation?
We're certainly very, we believe utterly in consumer involvement. And a lot of our work is informed in various ways by consumer involvement.
But is it more valuable, the outcomes of any trials or whatever the intervention is it more valuable because consumers prioritized it or assisted in the development of the protocol? Is there any way of calculating that?
So it's a great question, Sonia. I don't know that anybody's done that. I haven't seen that. From a values congruent position, I would have to say, of course it would be, because we're involving the people who are affected. I haven't seen anybody actually do that analysis, though. Rosalie Lupfen, have you seen any such analysis?
Not in that way. Not if you think about it as a formal cost effectiveness.
Yeah.
But what I was going to say is that when Richard was talking about choice experiments before, that is definitely a way of us being able to be broader in our thinking about what might most matter to consumers, to making sure that we have ways of capturing those things. And I can't overestimate the importance of thinking beyond what the clinical measure might be or that outcome, to thinking about what matters to consumers and their family, to patients and their families, when we're thinking about what it is that we should be measuring.
Yeah. Sorry, Joe, I see you've got your hand up. I just want to reiterate that study, that discrete choice experiment I presented on or went over briefly on contralateral prophylactic mastectomy. Two of the researchers in that were women with experience of breast cancer. So they were researchers embedded in it. I know that doesn't address your question, Sonia, but we very, very strongly believe in consumer involvement as informing not just interventions, but informing research. So, but I think it's a great question. I think be a great PhD for someone. Sorry, Joe.
No, I agree. It's a really great question. And I was just thinking about, although there may not be research that specifically looks at the value of consumer involvement, from a psycho-oncology perspective, one of the methodologies that we use quite a lot is co-design. So engaging with consumers to help to develop the intervention. And I guess one of the consequences of that is if the intervention is developed based on not only just the evidence of a psychological intervention, but in such a way that it addresses people's preferences for engagement, then we actually see higher levels of completion or adherence or engagement with the content. And so it's sort of like an indirect measure of the value of an intervention, because you actually see greater adherence to treatment, which is measured in sort of in health economics and in outcomes.
Can I pose another question? I've spoken to Monica about this before, but I'd really like an evaluation done on clinical cohorts on the value of the collections of biospecimens and data. So, you know, we can't get funding, and we'd really like to demonstrate our value so that we can show that we're worthwhile having and keeping.
And you could certainly conceive of that as a type of evaluation. So crudely, biospecimen informed care versus not, or you know, the impact that having biospecimens might impart in diagnostics in terms of the value of knowing, because that's now recognised as a source of value in the diagnostic space. So could you conceive of an evaluation that looks at that? You know, here's a group of patients who've provided specimens. That's the value attached to their care. Here's a group of patients who haven't provided specimens. They've both undergone the same optimal care pathway, if I can use that term, but not meaning an OCP directly. But they've both undergone the same care. One's informed by the specimen, the other isn't. Is there a value?
I think that would be a big challenge.
Yes, it would be a huge challenge, a very big challenge, particularly if we come back to that attribution question, because you've got so many things going on with patients who provided a specimen at different time points. So you'd need to restrict it to a very particular indication, and I think a very particular point in their care.
Yeah, can I just ask? So what you're talking about there is it's obviously for the patient's care, but is it like it's also a research database essentially?
It's a research database. We've got 4,000 melanoma patients with biospecimens and clinical data and quality of life. If anybody wants to use it, please.
Yeah, I actually think in some ways that's a return on investment question. And like all return on investment questions, there's not a linear answer to it in a way, if you like. So when we invest, I mean, I like to think of the analogy of when you invest in, you know, sort of basic biomedical research and people say, what's the return on investment? Well, we don't actually know. And, you know, we know because the people doing the biomedical research, they probably do say they're curing cancer, but they're not really curing cancer. What they're doing is they're understanding a mechanism of action. And that mechanism of action might at some point in the future have a value in terms of a new drug or a new delivery system or new something. And it's that return on investment that you're interested in. But I don't think it's a good way to think about it in terms of the linear kind of approach, if that makes sense. Doesn't mean that it doesn't have value.
But that's a good question, Sonia, for us to think about more, especially in the context of prevention, of course, because these people that have given their time and after diagnosis and so on can be really helpful with regards to the prevention question, and then how we can, I guess, prevent downstream cases of happening given their risk profile and so on. And then, of course, the vaccination topic comes back in, Richard, which again you mentioned the HPV vaccination obviously is our flagship program that has immense impact already now, but you described that even there, quite a bit of health economics had to be done to justify it. So that's a really, really interesting case example that you raised there, that we can really learn from what it took to get to that stage, to really understand the biology, and then obviously engage people in the early detection first, and then the vaccine coming online. So I think that's an extremely valuable case example that you brought there, Richard, and probably different health economics methods have been used at different stages of that development to get to that final program. So that's really cool. Yeah.
Yeah,
But I'm sure there were cohort studies at some point in time in the HPV program as well, Sonia, collecting those biospecimens. So maybe if we go back to that case example and use it and maybe map it against other cancers and where they are at, and then maybe that could help to really show sort of in the whole trajectory of trying to eliminate a particular cancer or cancer impact, using cervical cancer as an example and mapping it against it might be one way. I don't know.
Sounds like another discussion.
Great. All right. Well, we are sort of getting very close to the end of our time. Are there any other burning questions for Richard and Rosalie? I'm sure people will have lots of questions once they had more time to really digest everything you presented. Maybe one last question then. So for POCOG members or anyone else who would like to really have the fantastic expertise of the health economics and also the quality of life office, Joe, what is the pathway that people could take to obtain such great input?
Yes, so because CREST and also CREST, which is the Quality of Life Office, are both Cancer Australia funded technical services that support the clinical trials groups, such as POCOG. If people do want, if they're members of POCOG or one of the other 13 cancer clinical trials groups, they can contact us at the POCOG Executive Office, and we can organise input on their concepts, on their protocols. All concepts that come to POCOG for concept development workshops will also receive expert input and advice from CREST and from CREST. Also, Richard, are you still running the drop-in sessions for? No, you're not. Okay,
no,
so
but we're always happy to have a chat to people, Joe. We
yes.
just dropped the scheduled clinics because no one was dropping in. So
yeah. So yes, you can also contact CREST at the their contact details are on the website and they were on the slides. So yeah, feel free to contact CREST or CREST if you want further advice and support.
Fantastic. Thank you very much. And I think Richard and Lutfun and Rosalie sometimes also attend the concept development workshops.
Yes, so
And,
yes, we'll have a representative at all of our concept development workshops. And our next one is on the 5th of December, and I think applications are very close to closing, but if anyone has a concept that they want to submit, contact Tiffany at the POCOG office and we'll slip it through.
Great. Well, with that, can I thank once more Rosalie and Richard so much for your presentations. Really, really insightful and valuable. I've learned a lot. And thank you so much, Joe and Tiffany, for organizing this. And on behalf of the Prevention special interest group. Thank you very much and have a good rest of your day. Bye.
Bye.